Hi, everyone. My name is Carolyn. I am a physical therapist with NovaCare. I have been with the company for 3 years now. I did my undergraduate degree at University of Delaware and then proceeded on for my doctorate in physical therapy at Western Kentucky University. From there, I did my clinical rotations at Villanova for my final one, and in that process began working with the company. Again, I've been here 3 years. I am one of the primary therapists at Villanova, and I work out of our Broomall location.
Hey everyone, I'm Kelly. I did my undergrad at William & Mary and I majored in kinesiology and health science. And then I went on to get my master's in athletic training at Moravian College in Bethlehem. I had a bunch of clinical sites that I got to be a part of for Division I athletics. I was at Villanova for 2 of them, really loved it, and then got hired on here by NovaCare, working as one of 2 athletic trainers with our track and field and cross country teams. So we're going to jump into our presentation for today. We're talking about running injuries. We've chosen a few common injuries to talk about, so we'll get started. So first off, we're going to just talk about what the role of the athletic trainer is for those of you who may not be fully aware of what we do. So we're the first person to be on the field if there's an emergency, if there's an injury. The athletic trainers at all the games, on the sidelines, all the practices. So if someone goes down, we're the first one to kind of see what happens. Our eyes are always on the field. So if someone goes down, we're that first line of defense. We can eval the athlete. If it's an overuse injury, the athlete will come to us. We can evaluate them and then make sure they get the proper care, whether that be to a physician or to a PT, or they stay with us, or a combination of the 3. So athletic trainer is always on campus, so we'll be typically seeing the athlete before they get in the hands of another healthcare provider. We also do a lot of injury prevention. So if an athlete comes in, say freshman year, and they have a history of back pain, we'll work on core strengthening and glute strengthening and all stability stuff to avoid any future injury and kind of get on the front end of it so we don't have to deal with injuries later in the year. And then we work with return to sport progression that kind of goes along with communication with the coaches and the athletes. The athlete's never alone in returning to sport after an injury. We work together to create a timeline. We work with the physician, the physical therapist, and make sure the coach is aware of what limitations the athlete may have in that process. So we kind of act as the liaison between the athlete and the coach. And then, like I said, we collaborate with physicians and physical therapists as well.
And that's one of the most important parts of an athletic trainer is sort of that unspoken relationship of the liaison between the injured athlete and the coaches to help them sort of guide their rehab back. A lot of times we get kids who are hesitant to tell the coaches that they're injured, afraid that they'll be held against them as far as playing time or anything else. And so a good athletic trainer helps sort of bridge that gap from athlete to physician and physical therapist, and then also back even to the coach to help guide that and make sure that everybody's on board with the rehab.
Based on that, the next line of defense kind of is where the physical therapist can come in. We are able to take the injury, determine prognosis, evaluate it on our own as well. But where it's kind of a little bit unique is we are able to get from varying referral sources based on whether you go to physician first or the athletic trainer first. What I mean by that is, as far as physical therapists go, most states now, and especially in Pennsylvania, we have what is called direct access clinicians. As a direct access clinician, a patient is able to come to us beforehand, before going to a physician, and we are able to see them for 30 days based on insurance. But we are also very good at then determining, is that need for the referral back to the physician immediate, or can we kind of see what's going on and then refer? Just bases off of exactly what's going on when the athlete comes to us. So we can get referrals from multiple sources, as far as from the trainer, from the physician, or just coming in based off of insurance. From there, we take the athlete through the rehab sessions. They're tailored specific to the athlete based on injury, based on what we see during our initial evaluation. As Kelly said, we also then work on the return to sport progression, but we do this alongside the trainers and the strength staff as well as a whole body of the sports medicine team. We also then collaborate with the physicians and the trainers as again as part of that whole team. Kelly, you want to do this one?
Yeah, so then just reiterating that again, it's not a one-way street. We're constantly communicating AT to PT, PT to physician, any combination of communication between those three parties. And then it may just not be simply those three medical providers on the team. Maybe there's a sports psychologist, a sports nutritionist. So we can kind of evaluate as a team and see, do we need to pull in other people, other professionals to help this situation as well. And then as far as the education piece, we as medical professionals are constantly learning, trying to figure out what the newest and greatest approaches is to these injuries, what's the most evidence-based way to deal with these things, and then also educating those around us. So we're going to educate the parents on what this injury is and how to help your child at home. If it's a college athlete, how can your roommate help you? How can you educate the coaches to understand better, this is why this person can't be running 10 miles today. So we're also educating those around us as well as educating ourselves constantly.
Dr. Smith, you want to share now?
Oh, he's on mute. Dr. Smith, you're on mute.
Yes. So if we can you guys just throw up that one, the next slide with the little running guy with the four colors?
Yep.
So basically today we're going to talk about a couple different common running injuries, how they might present to an athletic trainer such as Kelly, how they might present to a physician such as myself, how we might then use somebody like Carolyn to help rehab them and get them back, or if it's through direct access, how they might go straight to the physical therapist. So we'll talk a little bit about stress fractures. We'll also talk about IT band friction, Achilles tendonitis, and even some patellofemoral pain. So I will share my screen here. There we go. Screen share and flip to this guy and make this nice. So with running injuries, a lot of the initial evaluation will be history and examination, but also imaging can play a role, particularly for stress fractures, one of the first ones we were going to talk about. The stress fractures are often best seen on imaging. Usually an x-ray won't actually show them at first, but an x-ray is often a first line test to look for that, whether it's because it's faster and easier and something you can do right away and get the results right away. That can be very helpful. And sometimes we can see subtle changes on the x-ray that would suggest that there might be a stress fracture versus getting an MRI to get a little bit more of a definitive look at it. The other way you can look for stress fractures is with a bone scan, but that requires an IV and you get some pictures done and then you're brought back an hour or two later to have more pictures done. So MRIs certainly become a lot more of a common initial diagnosis of imaging for after the x-rays. So on the screen here, this is an MRI of a right and left lower leg. So what we often will call a tib-fib MRI. So the tibia is the bigger bone and the fibula is the smaller bone on the outside. And on the left side of the screen is the patient's right lower leg. When we do imaging, it's almost as if we're looking at them. So they're like our left looking at the screen is actually the patient's right. And, our right side is their left side. So on this one, our right, patient's left, there's a big dark gray tibia, which is normal in appearance. On the left side of the screen, there's a lot of bright white or swelling within the bone itself. So we don't see one big jagged line right through it of like a full fracture all the way through. Stress fractures are repetitive stress, wear and tear, and you start to get little cracks that can develop in the bone. And it usually happens because you get an imbalance of the normal bone damage stressors versus bone healing. So typically, if you're exercising, you can get some damage that accumulates over time, whether it be from pounding, from running, or whether it's just on your own, or if it's like running as part of a sport. And so what will often set these off is a dramatic increase in activity. So we typically will see these in the fall or sort of end of summer, around Labor Day timeframe, early September. Oftentimes in kids who weren't running a ton, maybe over the summer in June or July, maybe they were away at camp, and they might have been active but not have been running quite as much. And then they come back, they start their preseason sports for the fall, and all of a sudden they're running a lot more than they used to. And if they're maintaining the same level of activity all the time, the body can sort of keep up with it. But if all of a sudden there's a lot more activity on it, then you start to get little potholes and little dings and dents in the bone, and it starts to swell and cause pain. And so we tend to get these a fair amount in the fall. But I will say I've seen a ton of stress fractures in the past 2 months because of COVID, the way it sort of changed everything sports wise. Not a lot of people were doing a ton of vigorous athletics through the winter, whether due to the COVID surging or the weather changes, or sports sort of just starting to ramp back up. But then this spring, as things have really started to open back up and sports have increased, we're seeing kids go from not doing much to now doing a ton. Even something as simple as they might have been doing virtual school. So they're not even walking around the campus of their high school. And they're not even getting in, a couple thousand steps a day, just walking to class and back and forth. So all of a sudden they're going from sitting to now running a ton, and the body can't keep up with it. So you start to get some swelling in the bone, you start to get some cracking in the bone, and really it's sort of best treated with rest. So the thing about stress fractures is there's not a whole lot you can do for them other than sort of cut back on the inciting stress or trauma to the bone. So really what it kind of needs most is time. And this can be frustrating for some athletes who might otherwise try to push through an injury because they might want to try and just, play through it or just get through the season. But this is one of those things, the more you push on it, the worse it can get. And eventually what starts as a mild stress reaction or a little swelling in the bone can progress to a stress fracture where you've got significant swelling in the bone. And in this patient's case, there's even swelling on the surface of the bone, sort of between the muscle attachment and the bone itself, as well as deep in the bone. And then eventually it can crack all the way through. And depending which bone it is, it might even need surgery to fix it if that's the case. So stress fractures are a common thing that we'll present to athletic trainers, or we'll present to physical therapists or to physicians. And if they go to see a physical therapist via direct access and they're starting to do some rehab and just not making any progress, sometimes the therapist will refer them into the office to see the physician for evaluation, exactly for this reason, to see if there's if it's a tendonitis or a muscle strain or whatever, that should improve with the physical therapy. But if they're not making progress, then it might be because of these other issues deeper inside. So that's where the imaging can play a role. Or I've also had quite a few of these referred into me by the athletic trainer. So like Kelly was saying, it's not a specific, only goes one way. It's patients can go sort of all back and forth depending if they present to the PT first or the AT first or the MD or DO first. So it can bounce around, but good communication between the teams usually helps the most. So in this foot, the x-ray of the foot looks pretty normal. You could maybe argue, if you have a really keen eye, that there might be a touch of extra bone being laid down in the middle of the third metatarsal. And then on the MRI, there's some swelling here on the third metatarsal. You don't really see the first very much because of the way it's the slice is made, but that's your first, your second, your third, your fourth, and your fifth. So this is the little piggy that went all the way home. So that's the metatarsal stress fracture. We see that in runners quite frequently. And one of the themes that you might hear from tonight is that, at least in my opinion, and I think also in several other people's opinions, is that a lot of the time, all these injuries are related to not enough hip and gluteal strengthening and core strengthening. A lot of people seem to think that core means abs and abs alone and lots of crunches and sit-ups and all that stuff. But that's really sort of a interesting view of the core. If you think about it, the rectus abdominal muscles, or your six-pack muscles, which normally I would show you, but not appropriate on a Zoom, so I'll keep them down. But they go from your ribs all the way down to your pelvis. So you might have ripped washboard abs, like I may or may not have, and but that's not gonna really be your core. they're go from your ribs all the way to your pelvis. So they're kind of longer flexor muscles. So the real core muscles are sort of your pelvic floor, your gluteal muscles, particularly gluteus medius and gluteus maximus, and they help stabilize your pelvis, which plays a role in pretty much all these other things that we're going to talk about with lower extremity running injuries. And so much of what I see in active people, whether it's high level athletes on either high school or even adults who run a ton, do marathons, tons of distance. A lot of times they're so strong in their quadriceps and hamstrings, and so much of their training is in the frontal plane, and they don't go side to side very much, or if they do, they're sort of hunched over as they do it. So they're not using their glutes enough, and they become a little bit too reliant on the quads and hams, and the glutes help absorb a lot of the impact from above. So that's some stress fracture background, and we'll get back to a few more slides about it. But then the next thing we're going to talk about is the IT band. So just to do super quick anatomy refresher with the knee, you've got the femur at the top, you've got the tibia, which is the big shin bone, the fibula is the little guy to the side, you've got the patella in the front, and the quad muscle attaches to the patella, and then it comes down and attaches to the shin. There's the MCL on the inside, there's the LCL on the outside. What they don't have labeled in this particular drawing is this white band that comes down along the side here, goes right over this outside of this right knee and attaches right here on the tibia. And that is the IT band or iliotibial band. So it's basically this thick band of fascia that starts from the TFL or tensor fascia lata, but also part of the gluteus medius, and it comes together and goes all the way down to the tibia. And so it goes from the pelvis all the way at the top of the iliac crest, comes together with the TFL and some of the glute med, and becomes this tendon that goes all the way down here, all the way goes over the knee and attaches to the tibia. So it actually crosses two joints. It crosses the hip joint and it crosses the knee joint because it inserts just past the knee joint. So the IT band can be an issue with repetitive friction from running or other activities, sports, things like that. So with IT band friction, the IT band gets tight. And a lot of that is usually because the gluteus medius isn't quite working enough, and they're kind of overly quad and hamstring dominant. So the IT band's trying to make up the difference. And so then what happens is the IT band starts to really rub on this area. Now, there are some risk factors, people who've had IT band issues in the past. And if you talk to a lot of runners, they'll tell you about how they've done foam rollers for their IT band, and they'll roll it out and they'll stretch it, and just it continues to be a problem. And the reason is we just weren't born inherently or evolved to have really tight IT bands unless we foam roller them every week. So it's usually because of a muscle imbalance. So unless you get the glutes more engaged, so you're not relying on the quads and hamstrings quite as much, you're going to keep relying on the IT band to sort of make up the difference, and then that makes it tight, and then when it's tight, it rubs over the side of the knee. So the way it will present is typically an achy pain, diffuse pain over the outer side of the knee. So if you're looking down at your own right knee, sort of the right side of your right knee or the left side of your left knee, and usually they're fine day to day, fine walking around school, fine walking around work, or walking around home if we're working from home. And so it's more of a pain with running that usually starts after you start running, and then it'll gradually get kind of worse. And then usually once you cut back on running, it calms down. So this is one of those things that a lot of runners just sort of deal with or kind of suffer through without worrying about too much, because it doesn't tend to really bother them until they get going more in their sport. So there are some exam things we do to try and test it. What's really hard to show in a static picture, and I had a video that didn't upload well to this PowerPoint, is basically the examiner is the guy here in the white coat, and he's going to take this patient's hip and bring it forward and up and around and back down again in a big circle. And that then sort of puts tension on the IT band. And if that hurts, that's usually a cause of the pain. Now, a lot of times we can get this better with some ice, some relative rest, maybe some anti-inflammatories, modifying their activity a little bit. Sometimes if it's bad enough, we'll even do a cortisone shot to help sort of calm it down. Now, again, that, whether it's the anti-inflammatories or the cortisone shot, that's calming down the bursitis, which is the tight IT band rubbing over the side of the knee, and that causes friction, and the friction irritates the bursa. So the shots or the medicines are really just to calm down the bursitis, but that's like the several layers deep of the problem. The real issue is there's increased friction, and there's increased friction because the IT band's too tight, and the IT band is too tight because of not enough glute strength and activation of the hip from above, so the knee starts to drift in more, which comes into play when we talk about the other issue with the patellofemoral pain. So there are plenty of stretches you can do for the IT band. In this one, the patient's sort of leaning to the right, sort of sticking the hip out to the side, and that can be helpful. You can look at stretching alone, but again, stretching alone usually isn't quite enough. And if any of you in the audience are avid runners, many of you might have suffered with this a ton and tried your own rolling of the IT band. And usually if it's not getting better, it's because if all you're doing is stretching, we're not treating the underlying issue of why it's tight in the first place. So strengthening the hip abductors really helps a lot. Rarely people will get surgery for this, but most of the time they do not need it. Just a super quick side note, depending on the age of the kids involved or the parents of the kids, most of the stuff, particularly what we'll get to next, the patellofemoral pain, is very, very common. But just one thing that's another often frequent cause of anterior knee pain, particularly in kids, is Osgood-Schlatter's, which some of you might have heard of. Basically, it's an inflammation of the growth plate where your patellar tendon comes down and attaches, and typically comes on around growth spurts. It's usually the 10 to 14 year age range, but then calms down as their growth slows down. But just so not all knee pain is IT band and patellofemoral pain. There are other things too. So just wanted to throw that one out there. And then I'm sort of jumping a little bit out of a line with the other slides, but I'm going to hand it back over after this one. But basically, anterior knee pain is a big common complaint. So is this anterior knee pain? So in front of the knee, people usually call it around the kneecap. More common in women than men, but does happen in both. A lot of runners get it. A lot of non-runners get it. Because it's so common in runners, that's actually where it then gets one of its nicknames, which is runner's knee. So usually it's described as either patellofemoral pain syndrome or patellofemoral if you're a potato or potato. Chondromalacia is basically another name for it. That's like sort of the more technical description. It's talking about chondromalacia is like softening and friction and fraying of the cartilage in the back of the patella. And sometimes it's just sort of lumped in as anterior knee pain, which could also include like patellar tendonitis, which is sometimes called jumper's knee. So those are some of the common causes. But specifically for talk about running injuries, runner's knee is usually a dull pain that gets sort of sharp with running. It's usually described as being around the kneecap. We used to have this thing called the movie theater sign, where if somebody was sitting with their knees bent at a right angle, like when they're in like the old school movie theaters, like back when I was a kid going to the movies. But now between either Netflix or like if you actually go to the theater, they got like the nice like relaxing lounge recliners. People don't tend to sit with the knees like sharp right angle for so long anymore. But they used to say, oh, I can't sit in the movie theater. I have to like straighten my knee out when I'm doing it. So that's often a common complaint of it. And basically it has to do with how the kneecap is relative to the femur. And I heard it once described as really what we're trying to do is keep the train on the tracks. So basically the patella sits in this little groove on the femur between what's called the trochlea, sort of at the knuckle part at the bottom of the femur. And so really we're trying to keep good alignment. We're trying to help keep the kneecap centered in the groove so it's not drifting off from one side or the other. So it's a very common complaint. It's often felt with running. It's often felt with stairs. It's often felt with your knees bent for a long period of time, such as at the movies. One of the things that can come into play is sort of anatomic alignment, but it's not just anatomic alignment and doesn't mean that if you have chondromalacia or patellofemoral issues, it doesn't mean you always have malalignments. But if the hip is wider relative to the knee and the knee goes in more, it causes what we call a Q angle. So it's basically the angle of like your tibia through your kneecap versus your length of your femur here. So if that increases, then basically if the knee is drifting in, the quad muscle is still attached up along the femur and at the top of the hip. So if your knee drifts in, then relatively the kneecap is sort of going out a bit. So it increases the force of that kneecap sort of sliding out of the groove to the lateral side and can hurt. And then if you have really flat feet, that can aggravate it as well too. So sometimes you can have the hip and the feet combined and it can really aggravate things even more. So there are different things we can try for knee pain, particularly patellofemoral pain. You can try anti-inflammatories. They can help short term, but they don't really do anything long term. For treatment, we want to protect the athlete and get them back into exercise safely. So we do relative rest. We don't completely shut them down from everything. We do allow some activity, but we don't want to have them overdoing it. And basically we try and ramp them back up. But one of the big things is really getting them stronger. And that's where good rehab can come into play. And for some of my athletes that are injured, sometimes I'll have them do a day or two a week of outpatient physical therapy with a physical therapist. And if they're at a school with a good athletic trainer who has like the time to do some of the rehab, sometimes they'll even do a few days of like rehab with the athletic trainer at the school. So the two can work together, and that can be helpful. So it's really about working on strengthening up the knee strength and the hips and the glutes. So those can all be helpful. So we want to try to not overly stress the knee and have it hurt a ton, but we can certainly strengthen it a bit. One of the things that people do at the gym all the time is the seated leg extension. Sort of like this guy is sitting at this like red machine thing here. It's a common machine. It's at most gyms. It's easy to do. So lots of people love it, but it's pretty rough on the kneecaps. I usually tell people not to do this one, or if they're going to do it, basically just use the weight of their leg and not anything else, or make sure that they don't have your knees all the way back, so that you want your knees a little bit straighter. Because if you like, if any of you took physics, you kind of remember that for each force, there's an equal and opposite reaction. So basically, if you're pushing against this thing for say 80 or 100 pounds or 200 pounds or whatever, there's a similar force pushing back this way, basically driving your kneecap into your femur. So it's better if you do a leg press, which then the force is going down and away from the feet, so then it doesn't put the same strain on the kneecap or on the patella. There was a really good study they did in Indiana, in the town of Muncie, where they did this exercise to basically have the patients sit forward and roll their foot out. So they kind of externally rotated it a little bit. So your right foot would be sort of pointed at maybe 1:30, 2 o'clock, left foot at like say 10:30. And you basically just lift up a couple inches to kind of try and activate the quad. But when you turn the feet out a little bit as you do this, you're sort of preferentially targeting that inner part of the quad called the VMO, because the quad is the quad because it's made of 4 muscles. So if we strengthen up the inner one a little bit more, it helps pull the kneecaps back in, because again, remember the issue is knees going in, which pulls the kneecaps out. So we want to push the knees out a little bit and pull the kneecaps back in. And I will hand it back to my compatriots and they will take over. Ready for you guys.
All right, so as Dr. Smith just said, these are some of the most common injuries that we see as far as the runners are concerned. So he went through a little bit of the background of that. Kelly and I are going to go through more of signs and symptoms and recognition of these based off of the complaints from the athlete themselves. So stress fractures. As Dr. Smith had alluded to, here's kind of a demographic of percentages of where the stress fractures are most common. Tibia, fibula are obviously the most prevalent here, but there's also these other sites of injury that we typically see as far as running is concerned. Some of the signs and symptoms that the athlete may typically mention, complain of, things like that, is that night pain. It's typically night pain after increased activity, things like that, or sometimes it could just be gradual onset without a specific injury. They will typically complain of it as being more of an achy pain, or sometimes it will be a dull throbbing. It kind of runs a little bit of a spectrum as far as what the pain can be described as, again, based off of where within that stress reaction to stress fracture continuum that Dr. Smith was mentioning. A lot of times it is tender to just touch the area, and then, they complain of that aching in that area based off of either just doing activity or sometimes, again, with that night pain. Swelling can sometimes be evident, but again, it's not always, depending on where in the continuum it is, it's not always the first symptom that is seen. Some of these possible causes for stress fractures can be that increase in training load, the improper footwear. As Dr. Smith had mentioned, the poor glute and core engagement. Typically, it's coming from somewhere else as far as that muscular imbalance, as the pull of the different hamstring, quad dominant, and the glutes not firing properly. As he mentioned, we have the core, which I personally always consider it as shoulder down to mid thigh. So that encompasses all of those muscles that are within there that you really want to make sure you're targeting. Another possible cause is inadequate nutrition. As far as that is concerned, is if you're not getting the proper nutrition, a lot of times the body will pull the calories and the nutrients to different areas, and it decreases that bone health. So that can also cause that stress reactions.
Yeah, so then going off of that, what do we do once the athlete is diagnosed, they see Dr. Smith, they have a stress fracture, what do we do with them? So the first thing is to make sure they stop activity. And he kind of alluded to this earlier, not necessarily sit on the couch, eat potato chips all day, but we can work on the things that cause the injury. So we can get them with the athletic trainer or the PT to work on glute strength, toe mobility. They can work on core things. Anything that's not going to involve the actual injured body part is actually good, so that when they're able to go back to their sport, they're stronger and they won't have risk of having the same injury again. So we'll stop activity, they'll be referred, and they'll have imaging to determine exactly what stage of the stress fracture, if it's a stress fracture, stress reaction, that'll kind of help determine timeline as far as healing and when they can get back to sport. We'll also look at their foot posture assessment. So that means, is their foot, they have a high arch, do they have no arch, is their foot flat, do they walk with their feet in, out? Because a lot of times if they have flat feet, it's going to be putting stress on areas that if we support them with a simple orthotic, that could help all the problems go away in the future once they heal. And then, as Carolyn said, with the sports nutrition, a lot of times it could be as simple as not getting enough calories in because they're so active and they just don't realize, or I don't have time to eat breakfast in the morning. So if we feel as though they're not getting any better, maybe we look to send them to a sports nutritionist to up their calcium, up their vitamin D, things like that, to help with those bone health. And then as far as returning to activity, once they get the green light from Dr. Smith that you look good on the x-ray, it's not just going to be, okay, you're cleared, you can go run a 10K. It's going to be a gradual progression. And that's where we can work with the coaches, the parents, and the athlete to say, okay, this is what you can do, X, Y, and Z. You can run 2 miles today and bike the rest. And then you gradually build up to that 10K that you're aiming for.
Moving right along, then we go into the Itvam friction syndrome. As Dr. Smith had mentioned, it is a long fibrous band that crosses the two joints, goes from the hip down to the tibia as it crosses then the knee. So there's different sites where it can be injured, and those common sites are typically friction at the hip or friction at the knee based on those points of contact. Some of the signs and symptoms that the athlete may complain of are pain that increases with the activity. Again, as Dr. Smith had mentioned, the pain is not always there at rest, especially with something that is a friction-based syndrome. There can also be some swelling. And then because it is that friction based, it's that clicking or rubbing feeling on either the side of the hip or the side of the knee. As mentioned earlier, some of the possible causes typically will be that weak and or tight hip. So is it that it's too tight in the hip that we need to stretch it? Or is it that muscular imbalance where it's the weakness between the glute, the core muscles, and that imbalance of quad and hamstring dominant, as most runners are that linear pattern? From there, we also then have the increase in training that can cause that friction. We're increasing mileage, but we're not necessarily using the proper training techniques. That's when that friction can occur, because we're increasing things without addressing the issue at hand. Another thing, as mentioned, was the increased knee valgus. That valgus moment is the knees are coming in, patella is shifting out. So we need to, that makes it look more of that bow-legged image that we kind of see. So with that, we have the bowing in, and then we have that, again, that increased friction. So as we also mentioned, it's typically not necessarily that it's the friction or that it's the IT band itself, but it's typically because of the dysfunction that is elsewhere.
So then keeping with the IT band friction syndrome, like Dr. Smith had mentioned, we need to stop activity. We need to calm down the inflammation. I think the most important part is to make sure that we try to get that inflammation down. That can be ice, NSAIDs, injection if he seems like that's necessary and it's not getting better over some time. And the athlete can see their athletic trainer for an evaluation on campus, and they can try to help point them in the right direction. Is this something that we can rehab and strengthen at school, or should they see a PT? Should they see a physician? And then they can begin to PT to address those weak or tight areas. So they're going to do some strengthening of the glutes, the core, the hip, all the muscles that surround the hip, so that they can support that IT band and it's not getting so much stress on it from those quads and hamstrings. And then same as the other injuries, they're going to gradually return under the supervision of a PT and AT, focusing on volume control while still maintaining what they did in PT. I think a lot of times athletes will be like, okay, I'm done with PT, I never have to do it again. But it's a long-term approach, and it's something that should be incorporated into their daily routine, whether they set time before or after practice to continue to do those exercises to keep up with their strength and flexibility so that they avoid any future flare-ups of this IT band syndrome.
Next here we have Achilles tendonitis, which again is a pretty common injury as far as runners are concerned. Achilles tendonitis can typically present in two different areas, whether it be where the muscle meets the tendon itself or where the tendon then meets the heel. It is a tendon, so it's muscle attaching to the bone. So the pain can be, though, anywhere along that tendon. We also have reduced motion in the ankle because of either tighter muscles or that inflammation that is causing swelling and thickening of that tendon so that you cannot get that full motion that we're used to. Another common complaint is pain with jumping or with stretching. Again, because it is a tendon, it's either going to be activation of the muscle that increases the pain, or it's going to be stretching to it because you're lengthening through that tendon itself. Some of the possible causes, as with most of the running injuries, could be the overuse or over-exercising. A big one with Achilles tendonitis is running on the uneven surfaces, and that's because you're trying to, especially going the different hills, you're trying to increase that motion in the ankle on a stretched tendon. So with that inflammation, you're not necessarily able to get that full push off, so you're increasing a little bit of a breakdown in other areas of the tendon. Again, with most of the injuries, it's that sudden increase in the training intensity without proper warm-ups. Tendons like to be properly warmed up, and it's not a warm-up as we're just sitting down and stretching. It's getting a dynamic warm-up set in place as far as priming that tendon, priming the muscles to begin that exercise. Another big one, obviously, is with improper or old footwear. Especially when it's old footwear, there's that breakdown of the shoe, of the bottom of the shoe. And with that, you tend to then put increased stress on the area. Along with the signs and symptoms, you also have the tight calf muscles itself. If the muscle is tight, it's going to be pulling on the tendon in different ways. So because of that, you can then get the increased inflammation and that shearing force with the tendon. And then poor foot posture, which we tend to look at with most of these injuries.
So then as far as treating this injury, we're going to stop activity like we tend to do with all these injuries we've talked about. We're going to refer them to a physician or a PT. The athlete's going to go through a period of relative rest. They're going to take NSAIDs. They can use ice. Some modalities that the PT or AT can use, they can use do some like deep tissue work or instruments that we have to do kind of breakdown of adhesions within the muscle. So there's a lot of things we can do to work on the cause of the cause, which tends to be that tight calf muscle. And then during PT, they also will work on foot mobility. A lot of times another cause could be lack of great toe mobility, so we'll work on that. And then the athlete, if they have lack of toe mobility, they're going to compensate in using their whole foot instead of just their toe. So that's something else we can work on. And then that gradual return to activity. So Achilles tendonitis can be tricky. We might place them in a shoe with like a heel lift, or you may know as a heel cup just for a time being, but it's important that we get them out of that because otherwise your tendon gets stuck in that shortened position. So over time, we want to try to increase the range of motion, increase the stretching in the calf, but to make sure to do that once the inflammation is down.
The last injury here that we're primarily focusing on is the Patellofemoral pain. So that could be, it typically presents as that anterior knee pain, but it can be up top of the patella, bottom of the patella, things like that, just based on what is going on. So the clinical signs and symptoms, the athlete will complain about the pain surrounding that kneecap. You also then have, it's tender to touch around the borders of it. As I said, it could be above, below, it could be on, inside, outside of the patella itself, but it's typically pretty tender to touch there. With patellofemoral pain, it tends to be a progressive onset rather than just an exact injury. And again, that goes along with the training principles. It tends to, a common complaint is that it starts with pain at the end of the exercise or activity. And that, again, is because you're stressing throughout the full exercise, and then that's when some of that breakdown, especially with fatigue of the surrounding muscles. Other symptoms is that it could be during all activity or normal walking, and that's when it's further into the symptom provocation. Some of the possible causes, as with all of these injuries, is that it's overuse. Where we have to kind of play around is figuring out, is it too much too soon or is it too much for too long? So there's different variations as far as, are they doing too much just at one time without, a gradual increase of activity? Or is it they're just doing too much that their muscles are fatiguing out and cannot withstand that full length of the injury or full length of the activity? Decreased quad strength, and Dr. Smith had alluded to this, was that it's more so some of that VMO action, as it is the four muscles within the quadricep group, but that VMO tends to have the least amount of strength. So we need to progress that strength in order to then increase overall quad strength. And then, again, as with most, it's that weak hip muscles or the weak core muscles. As far as recognizing and treating for the patellofemoral pain, typically once there's symptom provocation and the athlete is complaining of that pain in that anterior knee, we tend to go on what's considered relative rest. Again, depending on when within the actual injury stage we are. Once we have them on the relative rest, they can still be doing exercises as far as PT is concerned, or as far as rehab with the athletic trainer is concerned. With that, we then to strengthen the hips, the glutes, we do core muscle strengthening, and then we kind of go through the chain as far as making sure where is the weakness? Is it down in the foot that's leading to the varying pulls, or is it up as far as the glutes and the core are concerned? We also then can stretch what is tight. So is it, that our hip flexors, our hamstrings are tight, that we having a decrease or change in the pull of the mechanics? We take that and kind of evaluate and see what's weak, what's tight, and we then base our treatment off of that. Throughout the entire process, it's all about the education. We're constantly educating them on the rest strategies, on varying mechanics, on footwear, anything like that. But then from there, we can also go into the running modifications. Typically with all runners, we do a running assessment as far as watching them run, seeing where the breakdown is. We top-down approach or bottom-up approach, whichever the therapist chooses to do, but we take those running modification or take that running assessment and see where some of that breakdown is, and see if that's what could possibly be contributing to that anterior knee pain. Another aspect is typically a lot of times will recommend orthoses, and that being will look to see, is it because the foot is collapsing? Is it that it's weakness of those foot muscles? As Kelly had mentioned with Achilles tendonitis, is it coming from the toe? We're not really sure. So we have to take everything, look into it, and see what is our best recommendation. And then, as with all of the injuries, it's always that gradual return to activity. We never just throw them right back into running exactly what they were running to start. That's why they were here. We need to address the imbalances, get everything stretched, strengthened, and from there. And then we gradually increase that activity and see, is there still a breakdown? Is there still something we need to work on? And then we're constantly in that collaboration as far as with the athletic trainer, with the physician, as if they're doing follow-up appointments with the doctor and going from there.
So then now to kind of round things out, we're just going to talk about the role of the parents and the coaches. How can you help the athlete kind of get pointed in the right direction? So we came up with a few rules, things to help you out. The first one is to listen to the athlete. I think Dr. Smith kind of talked about this right in the beginning of the presentation with stress injuries. Sometimes kids are afraid to speak up. They want to play through their sport. They want to be the hero. They want to play in the state championship game with a stress fracture. But we need to be aware of if they're limping, if they're performing poorly, that they don't normally perform that way. Are they telling you they're in pain? We need to listen to our athletes. The second one is to be observant. So that goes for the athlete that may not want to admit they're in pain, but you can kind of tell that something's off either through their face, through their physical demeanor, maybe they're mentally struggling. So be observant and see what seems off. How can I help this athlete? And then we want to encourage them. A lot of schools nowadays have an athletic trainer on campus. So that's a great resource for the athletes. We want to make sure that we're welcoming. We want to make sure that the athlete feels comfortable to talk to us. We're always willing to speak with them, whether it's a mental health injury, a normal physical injury. So if you encourage the athletes to talk with us, it'll kind of be normalized, and then we can help get them the help that they deserve and should get. And then the fourth one is to discourage playing through injury. No one should play through an injury. I mean, there's some special circumstances. Maybe it's your senior year, last game of your whole career, and you want to play through a sprained ankle. Like, we can work with them, but promoting them to speak up when they're hurt, not play through an injury, so that it doesn't lead to other things down the road. And then the fifth one is to communicate, like we've talked about through this whole presentation, communication between parents, coaches, the whole sports medicine staff team. We're all here to help the athletes. And if they are comfortable speaking to all of us and we all have their best interests in mind, that communication is really going to go far in helping them get better. And then the last one is to support the athlete in whatever process or journey they'll be going through. Some injuries may be 1 week, some may be several months. So just support them, be aware if there's any other underlying things going on. Maybe they are mentally struggling and you do see them kind of withdrawing or not wanting to be with their teammates because they can't participate physically. So just recognizing those things and supporting the athlete through the whole stage of the injury.
All right. Thank you all. That was wonderful, very informative. Right now, we're going to open it up to any questions and we would be happy to answer them as long as they're not too detailed, specific. But feel free. There's a little button at the bottom of your screen that says Q&A. You can type your questions there, and we will answer them for you. In the meantime, again, if you want to make an appointment for Dr. BJ Smith, that VIP line is 610-480-6584. Again, 610-480-6584. He sees patients in Bryn Mawr, Lincolnall, and Limerick. Give you guys another minute if there's any questions, and we'll answer them. If not, then we appreciate everyone being here tonight.
There was a question about Piriformis Syndrome, which we clearly didn't have the time to get to because it was a lot just to talk about those 4 things. So, certainly it's something that all 3 of us are able to evaluate and to look at. We do see it a fair amount also in runners, often goes along with the glute med and glute max not firing enough and too much reliance on the quadriceps and hamstrings. And then the hip rotators have to kick in to help more, and it overloads the piriformis a little bit. So it's similar in some ways and different in others, but it is worth getting looked at if it's bothering you.
Thank you.
The other numbers listed here as well as the website are to, we have the email address is for the sports medicine team at NovaCare. And then the phone number is able to allow for scheduling for appointments. You can also go to the website novacare.com and type in locations and see which clinics are more geared towards the sports medicine, which are geared towards general orthopedics, things like that, and able to schedule appointments that way.
Great, thanks, Carolyn, for saying that. There is a question that popped up. What would potentially be the cause of posterior knee pain that may radiate medially?
That could be a couple different things. It could be a Baker's cyst, which is like fluid behind the knee. It doesn't mean that you make too many cakes or brownies. Baker's cyst is like when you get extra fluid in the front of the knee, it kind of leaks out between part of the calf and the hamstring, and you get some fluid behind the knee. And if that's the case, that could sometimes be drained. But if it is a Baker's cysts are annoying. It's kind of like, just general water on the knee or fluid on the knee can be annoying, but they're not like the only issue in and of themselves. The analogy I like to use is it's kind of like smoke from a fire where there's something going on deeper inside the knee that's burning, and that's making the smoke or making the extra fluid in the knee, and that some of that the smoke will sort of escape, and that makes the Baker's cyst. So if all you do is open the window to let the smoke out, but your kitchen is still on fire, like it's not really helping. So part of it is treating that, but the next part is to also try to figure out what is sort of angry deeper inside the knee or whatever joint is swollen that could be contributing. So it might be a Baker's cyst, it could be a meniscal tear, it could be a hamstring strain, it could be the pes tendons. There's a bunch of stuff all in that area. So it's sort of hard to say via Zoom what that would be without like being able to fully evaluate it. But if it's something that's bothering you a lot, it's probably worth getting it checked out.
Thank you. All right, guys, if there's no more questions, I just want to take this time to thank all our panelists, Kelly, Carolyn, and Dr. Smith, for being on here tonight. And thank you all for attending. All right, have a good night.
Thanks, everybody.
Thanks, everyone.
Take care.
Bye-bye.